My name is Guelay Bilen-Rosas, and I'm a physician, and I develop a novel respiratory monitor that uses ultrasound to predict breathing change, respiratory changes. But I'm also the director of the pediatric transplant anesthesia program here at UW, and I have the greatest privilege of working with kids of all ages. What I do is I administer anesthesia and sedation. When I do that, I take my patient's ability away to breathe for themselves adequately. I become their lifeline. If I am unable to recognize when their breathing is compromised, and if I am unable to support their breathing at that time adequately, the next thing I know is the patient turns blue, the oxygen would have dropped, and I have this fear in my stomach. What if I cannot bring that baby back? There's a parent on the other side. I'm an airway expert with about 20 years of anesthesia experience, and my patients under my care are still suffering breathing complications. And it's not just the babies and the children that I care for. It's the teenager in the dentist office who's receiving sedation for wisdom tooth removal. It's the adult who's going to the GI clinic to have an endoscopic procedure under sedation. It's the grandparent who shows up in the ER with pneumonia. So why are we unable to accurately see when and how much breathing changes? This is because currently standard monitors that are available to us are non-respiratory monitors. They measure heart rate, blood pressure, and oxygen. They're indirect monitors. They do not measure breathing. What they measure is they measure the effects that happen to the body after a respiratory event has occurred. At that time, they alarm. When they alarm, the patient has been in a low stage of oxygen for an unknown period of time. At that time, the recognition is delayed. We're interfering too late, maybe sometimes, and we're risking at that time injury to the brain and heart and even death. Because we do not have a really direct monitoring tool, what do? We use our clinical tools. I use my 20 years of anesthesia experience to make my best educated guess about my patient's breathing status at that point. It's quite frankly dangerous. Clinical clues are subjective, and you cannot teach 20 years of airway skills to any provider, no matter what their skill level is. To fill this need, our group is working on a non-invasive, wearable respiratory monitor that will monitor your breathing directly in real time and will give real-time alerts about your breathing changes. And what we do that by using ultrasound. We take ultrasound and we throw it to your neck, we send it to your windpipe. At the windpipe, that ultrasound signal is altered by the airflow that crosses the windpipe when you're breathing. That altered signal comes back and actually correlates with respiratory rate. It correlates with airflow, with you breathing in and out, and even with apnea. People say, oh my gosh, Guelay, how big is that scope of that problem you're talking about? How big is the market? And to be really honest with you, the very sobering answer is, it is very hard to accurately tell you how big the market is, how big that problem is. How can you identify and report something if you do not have the tools necessary to actually measure it? How do you do quality improvement in your company? You measure. Me as a healthcare professional, I'm speaking on behalf of all my colleagues, breathing complications are a very big, dangerous problem. So what we do is to infer the scope of the problem. We actually look at newspaper articles. We look at registries, which are incomplete, that have been accumulated over the last 20 years. We use our detective skills to look at secondary causes of death, because we don't have really something that can timestamp the primary cause of death. And not every bad outcome makes it to the news. But what we can tell you, though, is gathering all that information, the economic burden on even minor medical complications, such as a drop in your oxygen level resulting from sedation, is a $2.2 billion loss per year in the US alone. And that does not account for severe complications or even death. And let me tell you another scary fact. Over the last 20 years, there has been a 300% increase in the number of cases that have been moved to the outpatient and office-based setting. So what does that mean to you? To you, that means the further you're removed from the hospital setting, the medications that I am allowed to use and give to my patients are being administered by healthcare professionals who are not airway experts and who, quite frankly, lack the skills to recognize and rescue an airway. It's just a big problem. To fill this need, our team is working on a technology, and our team consists of people, physicians like me, such as Dr. Bilen-Rosas, who happens to be also my husband, so if I call him honey, it's totally fair, okay? Dr. Irene Ong, who is an expert in machine learning, and our wonderful graduate student, Lin Chi. To date, we're holding 5 patent applications, and we received the Wharf Innovation Award at exactly the same event like today in 2016. We have received the Wharf Accelerator Phase 1 and 2 funding to collect our data and create a prototype, a hands-free prototype that we're currently using to collect data on sedation patients in clinic. We're really looking to commercialize this technology to make a big healthcare impact and to improve the outcomes for our patients because, ultimately at the end of the day, it is about our patients. As we're continuing the development of our product, we would love to speak to people who can guide and advise us to move this technology forward because great things do never come alone. Again, my name is Guelay Bilen-Rosas, and on behalf of my team, I invite you to see us during the networking session, and we would love to talk to you. Thank you.
All right, we have time for just up here, 1 or 2 questions. So there's microphones around the room. I can start off with a question. So I'm a chemical engineer, and we measure flow all the time. Why hasn't there been a device like this? Why isn't there a device like this on the market already?
Yeah, so it really is not a, does this work? Yeah, it really is not of lack of effort. People do recognize the need that we do not have a real respiratory monitor. But I think none of the currently available methods, technologies actually capture everything that is needed to give the information for the entire respiratory phase. Like such as belts, they're attached externally, and they interfere with motion. And when you still can have, for example, thoracic impedance change, but even against the closed glottis, even if you have an adverse event, it will not recognize it. Anything that attaches to the mouth, to the nose, to the face, like thermistors, it's hot wire anemometry, measuring the differences in temperature change. They are not then measuring the complete breath. So there are many other examples, such as vision sensors that require active participation of the patient to lie still, or spirometry. So there are methods out there, but what the community has struggled is to actually find something that encompasses all the requirements that are needed to give a meaningful measurement of breathing, and especially not interfere with normal daily activities.
Any other question? Do we have any?
So how about if you were to measure the oxygen level? That's what we measure. Don't you know?
We do that now, but oxygen is only the consequence that happens after a breathing problem has occurred. And oxygen in the pulse oximetry in the presence of oxygen can be as delayed as by 10 minutes. We call this apneic oxygenation, right? And so you can have your arterial oxygen level can drop, but your actual monitor will not capture that until you actually fall off the cliff. So it is not a real life monitor. It is only a monitor because of the consequence that can be seconds to minutes, depending how, what other comorbidities a patient has. So, that is what we're scoring. By the time, and to be honest with you, I'm a pediatric anesthesiologist. I see my patients turning blue and my oximetry is 100%. It really is pretty meaningless to me. And the other thing is what I always, as a person that, I work with monitors, so I can be very critical of monitors, even though I'm developing ones, I'm very critical of myself, is there's so many false alarms, we just pause them, right? They're not meaningful.